So instead, I'm going to start with a joke. You guys heard about the joke about constipation? Hasn't come out yet. I heard it on the radio, sorry. So, hashtag doc jokes. So I'm going to be talking about the last hours of life, okay? So this has always been kind of a contentious topic. I think I was blocking my video. Wait, I'm supposed to stand over here. Okay. So the problem is I need my pointer. Sorry, we're not. You guys didn't set me up properly here. Sorry. I'm going to have to start over.
I can push a button if you want me to.
Hold on.
I can do that. Oh, he's got a pointer.
Okay. There you go. The highlight isn't working. Okay. Technical. So when the body stops, pain and shortness of breath in the last few hours, okay? So this is a very critical time where our services are needed. But there's lots of thought that goes into this. You know, when it starts when we admit the patient. So our objectives for tonight is to just talk about what constitutes a good death. Do we even think about a good death for our patients, or we just kind of go into our mode usually? But we never think about what really is important to them and what is really a good death. Everything going wrong this morning for my presentation. We need to recognize the signs and symptoms of a dying patient. We need to utilize hospice, because when we utilize hospice, it increases the chances of a patient getting a good death. Recognize your legal and moral duties about treating a patient, because there's going to be all these, sometimes, you know, morphine kills patients and all these things that you get pushbacks on. Understand the principle of double effect. I'll explain that later. And understand the proper use of opioids and symptom management at the end of life. So, what's a good death? There's many studies. They've done thousands of papers on what do patients really look for, what do they want. One of the things is a place of death. If you ask Americans, 80% of Americans want to die at home. What are the numbers? 60% die in the hospital, 20% die in a nursing home, 20% die at home. So it's very far from the wish of most people. And why is that? Perhaps trapped into the usual mode of care that we're presented with, send them to the ER, do all that stuff. That's where we come in. That's where we could maybe make a difference. What's important to them spiritually? What's important to them emotionally, their families? And most of all, what is their prognosis? A lot of them don't understand when they're going to die, why they're going to die, and that's also part of where we can intervene and say, this is what usually happens when you have these kinds of things. Not to say that it's for sure, but these are the things we can do to plan. So you need to talk to your son and have closure before this time comes. Because if we don't do that, then that adds to the stress and the, you know, I guess for a dying patient, that they don't get to fulfill what a good death is to them. So recognition of pain, symptoms, and management, that's where this whole talk started about, or was kind of spurred on by, you know, pain management at the end of life, because some facilities don't want to give the morphine, or, you know, they're afraid of killing the patient and all this, you know, all these myths. We'll talk a little bit more about that. Spiritual and emotional needs met, presence of family and loved ones, you know, and we need to facilitate that from so that they're not estranged from some of the family members. Okay, so this is more clinical, but it still applies to a non-clinical person. How do you know when the patient might be at that point where they may die within 3 days? So there's a whole list of stuff. Weak or no radial pulse, respirations with mandibular movement. You know, when they breathe, they kind of start doing that. Decreased urine output. Cheyne-Stokes breathing is when they kind of breathe faster and faster and faster, and then they slow down, and then they get faster and faster. It's like this rhythmic, and that means that the cardiopulmonary system is starting to suffer. Death rattle or airway secretions, we know about that. Non-reactive pupils, decreased response to visual or verbal stimuli, inability to close the eyes while sleeping. Oh, yes. Drooping nasolabial fold, hyperextension of the neck, because they're having air hunger, so they tend to kind of want to do that when they breathe. So these are like little subtle symptoms, you know, this whole list of dropping blood pressure, losing ability to swallow. So when these happen acutely, you know, let's say they weren't bedbound and all of a sudden they're bedbound now, then it's like, okay, are they close to that 3-day thing where they might start to die? None of this is absolute, but at least these are clues we can start thinking about. So when you guys in the field are seeing it, you can share it with the clinical team. The clinical team can respond accordingly. Okay, I want to explain this. Pardon the drawing, I just scratched it up on the iPad. But what this is a physiology of death. So let's just first start with the function of the body. When you eat or drink, food goes in the stomach. Stomach needs to be functioning. The intestines have to absorb the nutrients, the fluids. They have to be pushed out to the kidneys. The bladder has to get rid of it. The liver has to detoxify a lot of the stuff you ingest, right, and break it all down. And all of that is being driven by your engine. Your engine is the heart and lungs. So always think of that heart always pumping blood, right? And then oxygen entering through the lungs. You need that primary engine to run all these processes. When your brain is thinking, it's getting blood from the heart that's oxygenated. And you have, when you breathe, you know, everything, all these processes are connected. So think of a juggler. When you have, when you're juggling 7 pins, you know, you see those guys, or sometimes they're juggling chainsaws. So when one of them starts falling, usually the rest of it collapses. So it's like a stack of dimes, right? It's all connected. And eventually, this is the last thing that's going to go. And when that goes, you have fixed amount of symptoms that happens. So this is the primary engine. As everything shuts down, let's say your kidneys start blocking up. That means you can't eliminate the fluid, right? So then everything will start destroying the whole process until it gets to the primary engine. The engine can't work anymore because it's all full of fluid. Or, for example, your nutritional status is so impaired you can't get nutrition, your primary engine will start failing because of severe malnutrition, right? All the things start to shift. So just the message here is that this primary engine is the last thing to stop. And that's when life goes, is when the primary engine quits. Somebody's calling me, sorry. So these are the most common symptoms in the last days and hours of life. Shortness of breath, delirium, anxiety, noisy respirations, worsening pain, and nausea. So we want to kind of think of these because these are the things we need to manage with our medication, with our whatever we're doing. Sometimes it's not medication, sometimes it's spiritual intervention, sometimes it's just being with the patient. What about dehydration? That's one of the things that happens at the end of life because they can't take any more fluids. So I just want to emphasize, I know a lot of you know this, but these are the great effects of dehydration. So we have to capitalize on the side effects of getting dehydrated. You decrease the symptoms of choking, you have less coughing, less congestion, you decrease bedwetting, which can be, alarming in a patient that can't get out of bed. less GI distress, less bloating. If you try to feed someone and their system is starting to collapse, they can't ingest that food and be comfortable with that. Less diarrhea, less edema, less pain. They can be more sleepy. It has a sedative effect. Getting dehydrated helps you get sedated and sleep more comfortably. Less appetite, no hunger, no thirst. All these things, it's designed, the body's designed to shut down, and dehydration is one of those mechanisms. So if you can explain it like that to the families, they won't feel like they need to give IV fluids. So what are the effects of morphine? Morphine is kind of our all-encompassing comfort medication, which, and if you're allergic to morphine, you certainly have all other opioid options. They all act the same. They're all kind of different brands of, or Pepsi, Coke, Sprite, or Orange. It's all the same, of achieving, not exactly the same, but they can achieve what morphine achieves at the end of life. Pain relief, dyspnea relief, reduces CHF in a failing heart because it opens up your blood vessels, so everything kind of just settles down. When you have CHF and you give morphine, the venous system dilates, so that reduces the load on the heart. Okay. Anxiety relief, sedative effect, helps you sleep, reduces the sympathetic response. This is important. When that primary engine starts failing, your body releases all these hormones to try to survive. So that's what makes you tachycardic, that's what gives you the pain signals. So all these hormones are surging in your sympathetic nervous system, trying to fight that death that's coming. So it's inevitable to die in a very uncomfortable way because of the way the body is designed. So morphine does not hasten death. So this is how you need to think about it. If you and I took morphine, what's going to happen? We're probably going to sleep, right? But that's not going to kill us. So when you have a patient that's dying, the morphine is not killing them. It's just alleviating that discomfort and letting them sleep comfortably. Now, there is such a thing as overdose. So if you're never had opioid in your life and you get a big whopping dose, your breathing can get so slow that you could die. But that's extreme, okay? And you have to go from 0 to hundreds of milligrams of morphine. And this really, the clinical scenario in all my years where this happens is when they had the Duragesic patch, which is 25 micrograms. That is equivalent to 40 to 150 milligrams of morphine. So when you've never had morphine, when was the time we ever gave 100 milligrams of morphine? Never, right? We start with smaller doses. So that really doesn't occur. And so now they made the 12 microgram patch, which is smaller, because before the smallest was 25. So the clinicians were starting them on 25, not knowing it was hundreds of milligrams of morphine. So that's really the scenario that opened up this fear of causing respiratory depression in these patients. Okay, so ethical considerations. We need to treat pain at the end of life. It is the patient's right to get that treatment. So when the family is refusing, we need to fight against that in a way because we need to protect our patients. Pain treatment is a clinician's moral and legal obligation. There have been lawsuits where pain was not treated or addressed, and actually the plaintiff won because, So, myth. Small risk of respiratory depression with opioids, when used appropriately, does not justify withholding it. So that's what I was talking about. It doesn't really happen that much. Giving 10 milligrams of morphine, 20 milligrams of morphine to a dying patient will not depress the respiratory system. Okay? If you gave maybe 100 milligrams, then yeah, maybe. But it doesn't really happen. If you're trained hospice, you need to encourage them to to have a trust that we are trained, we understand medically, giving smaller doses and titrating up will not cause these symptoms. So here's we get to the principle of double effect. If you've never heard of it, it's aggressive treatment of pain at the end of life which is legally and morally acceptable even if your death is hastened, because you're providing pain control. That is your main goal. So the sedation or respiratory depression is only a side effect of your primary goal. So, the end just does not justify the means, right? So, but when your goal is to treat pain and you have a side effect of respiratory depression, that's acceptable in the legal and moral standards, because you're not trying to kill them, you're trying to relieve the pain, and if they die in the process, that's all part of it, and they do have a terminal diagnosis. So that's the double effect. Not to say that it's okay to have the side effect, but if the pain is not relieved, we need, so for example, a severe cancer patient with like pancreatic cancer can be really painful. What happens is, the tumor in the pancreas, sometimes those enzymes, they get released, like pancreatitis. Those enzymes are what helps us digest the steak we just ate. So can you imagine the pain that could be caused by all these enzymes being released? Just as a kind of an example. So when the pain is so severe, for them to achieve a good death, if we have to give them so much morphine that they stop breathing, so be it, because not that our goal is to have them to stop breathing, but we need to understand the principle of double effect. So if you're in a court of law and they know that this is what you're doing, there's no way that you will be in trouble for that.
I have just a thing to say too. When we were dealing with Thomas Lynch with this issue with the wife not wanting to increase pain medications, when I spoke to the ombudsman, she said the same thing, that because Tom is able to communicate that he is in pain and he needs something more for pain.
Yes.
The ombudsman said that as his activated power of attorney, her job is to see through what his wishes are.
Yes.
So even if she doesn't agree that he should have fentanyl or increased, if he's saying that this is what it is, that is his right.
Yes.
So this is all on this.
Perfect world example. Or, anybody else have any experiences with the double effect you want to share? Anybody? It's okay.
Well, education is the main thing. Like, last week I gave, on this, and out of 6 people sitting, 5 people said that they're afraid of giving morphine. And before that I started, and after making them understand, all 5 of them said, now we understand, and now we can give them morphine.
Thank you for doing that.
Yeah, no problem whatsoever.
Yeah.
I think that's really important, especially in the assisted livings, that they understand
Exactly.
that, because those particular med passers are very scared to give morphine,
That's true.
Yeah. So
more so than nurses.
Yeah, so to recap the morphine issue, they need to understand, first of all, that the doses we're giving are not enough to kill the patient or produce side effects enough to, we're trained to titrate it slowly so they don't have that respiratory. The risk of respiratory depression is very tiny. And 2, that the morphine is not killing them, they are in a dying process. So you can try to explain the way the body is failing, and we're just mitigating the symptoms that will come with that, right? Palliative sedation may be needed in minority patients at the end of life for symptom control. So there are some patients where, again, cancer patients where not just morphine isn't enough. We actually have to sedate them, like, put them into general anesthesia in a way. So those are severe cases that happen. So what do we do for management? Well, stop all non-essential meds, of course, right? We need to reduce that pill burden. And then the route, you have to figure out, okay, is this patient going to stop swallowing? So we need to think about, do we need rectal route? Do we need subcutaneous route? So we do have options for that. We have the topical with the patches. So this is a good one that I learned. So we can order the morphine and order it as offer but may refuse, okay? So we're always just thinking about PRN or scheduled. Well, we can actually schedule the offering, but write in the order that they can refuse it, so they don't have to always get it. And I don't know if that might fuel the nurses not wanting to give it, but but at least it gives us kind of like a middle option. So, in special cases, if you think that that might help, you can schedule it to be offered every 4 hours, but they don't have to take it. They can refuse. So, yeah.
One thing I just wanted to, in addition to everything else you've said, I think education of the family from day one
Day one.
about what we might be using, why we use it, how we use it. So as they see us, providing this medication to their family, by the time they get to actual end of
Yes.
life, they are saying to the staff or to us, I think they need more morphine. And
Yes.
if they get that dose of morphine, I think all of us have maybe had that happen.
Mhm.
You give a dose and then half hour later they do pass away. The
Yes.
family's okay with that because they've seen the progression, they understand from day one what you're going to be doing and why. So
Yes.
taking that time up front, having the conversation, documenting it, I think that really helps the whole
Yeah.
process.
Yeah.
Does definitely.
Upfront education before the crisis comes.
Crisis.
Very good point.
And it gives them some control too.
Right.
Yeah, it
Yeah.
gives them some control.
Very good. Very good points. So, and then I have some details here where, if they're opioid naive, you can give a smaller dose. We don't have to stick to our usual doses. If we think the patient is sensitive, you can give 1 or 2 milligrams of morphine. It doesn't have to be 5. We usually start with 5, 2.5, or 10. You can give 1 or 2. It might still have an effect. And then if they're already on opioids, you want to give at least 10 to 15% for breakthrough of the daily dose, because otherwise it's too small. So you have to be in proportion with, they're already getting 60 milligrams of morphine every day. You want to give them for breakthrough at least 10% of that, 10 to
10% of that,
15%.
exactly, and that's what I don't see right now, that if they are getting like 50 or 100 microgram of diuresic patch,
Yeah.
and then we are giving them 10 milligram of morphine every 4 hours PRN for breakthrough pain, that's not effective at all.
Yeah.
So you have to increase the dose. It is 10%, so make sure it's 10%.
Yeah, so
Whatever
we
the
should
day
be
schedule.
looking at that.
Yeah.
That message is for the nurses primarily.
Correct.
Look at the morphine dosing, and if you're not comfortable with that, talk to me. We can throw it around. Okay. So oxygen. A lot of us always go to oxygen right away when they are not breathing or where they feel short of breath, even though they're not hypoxic or they're not breathing at a fast rate. But a fan actually works just as good, okay? Because there's receptors in your face for air, that when you feel that air in your face, your shortness of breath goes down dramatically. So just a thought, not everybody needs oxygen ordered. Put a fan in their face, that usually helps. Okay? But if their oxygen is low, then definitely go to oxygen. It's more practical. Not only does it save money, it also gives them immediate relief. Okay?
And it's more comfortable.
Yeah, and they don't have to deal with the,
Tubing and all that.
reserve oxygen. Blah, blah. So Ativan is best for COPD patients. I always talk about that, but don't miss out on the morphine. And then there's all the adjunct medications we can give, but that's a whole nother topic. So we talked about those things. So think about a good death for your patient. Recognize signs and symptoms early. Utilize hospice, and because we are trained to deal with these types of patients, and understand what your legal and moral duty is for treating a patient, because you'll have fights with staff and family. Understand the principle of double effect, which we did talk about, and proper use of opioids in symptom management. That's it. Any conversation,
Very well.
questions?
Thank you.
Yeah. Go ahead.
Yeah, I have a question mentioning the heart and the lungs fail down. Is that because in the brain it's dying and it's communicating to the heart and lung? I mean,
What do you
kind
mean?
of, when someone starts to slowly die,
Okay.
unless we know it's cancer and it metastasized.
Mm-hmm.
But if it's just a slow death, where would be the connection with the brain to our organs that it just kind of slows down? Is it the organ or is it the brain?
No, it depends on what the cause of the death is. So,
Right.
let's just say the brain, you had a stroke, okay? So now your nervous system is impaired. So your nervous system controls all your organs. So then over time you slowly, you're unable to control your blood pressure, and the brain is atrophying, you're not moving anymore. So then what happens? Your bowel shuts down because you're not mobile. You're retaining urine because you're not mobile. You're not swallowing properly, so maybe you'll aspirate, then you might have more complications in your lungs. So you see what I'm saying? It's all kind of related to what that system is that has failed is helping the body with, and over time it'll collapse. But towards the end of life, when everything has been damaged, so to speak, then the heart and lung will eventually be the last thing to shut down, because that's what keeps us alive, right? Every breath we take. Oh, that's the song. Never mind. So, it's always the heart pumping. If that shuts down at any moment, you can't breathe. You're gonna collapse. So, sorry, she's laughing at my hashtag doctor jokes.
Hashtag doc jokes.
Yeah.
Roll the day, LT.
So, any non-medical questions or anything else?
Well, I'm just thinking if it would be wise if I could share this with some of my volunteers, because they are there when sometimes there's not a skilled nurse present, or these are just some things that they can report back to me that I can report back to the case manager.
Yes, I can give you a printout of this if you want, and you just email
I
it.
can put it in the training binder, and then I can revisit with them. So
Yeah.
I think she's also gonna upload this at some point to YouTube. Were you still thinking about
Well,
it
yeah, but
at some point?
I need a better setup because this is kind of skewed right now. When I do talks, I need like a nice, but we figured it out. So yeah, I mean, I'll put it up on you. We'll see how it looks. And
Two more coming up that we can record as well.
yeah, so I need to have like a setup like this so we can record nicely and they can see. Yeah, the slides. I'm not sure if the slides will show up well, but we'll see. Yeah. Okay.
Thank you.
Thank you.
All right. Thank you.
Yeah, I
Oh.
wanted the fresh air idea, the air on the face.
Yeah.
Are there families that request open windows and actual fresh air at time or in that season,
Yeah.
at that time? What facilities allow for that, and how does that work?
That's always a tricky one because they want to control the heat and all that. So that's a case to case basis. But generally, that's not always a good idea to open the windows unless you're able to and you don't cause too much trouble. But a little fan is certainly going to achieve a lot. And then turning down.
Taking some paper and while not every room has a fan in it, or nor do we all have a fan with us at times, but we could take like a folder until we're waiting for something to maybe just
Yeah, that's
wave
good.
some
In older days, they used to do
air in the
that.
face.
Oh, you mean when they're short of breath?
Yeah, only when they're short of breath, right,
Yeah.
if you're right there and you're waiting for something else.
Yeah, exactly.
Well, that's not really gonna have an immediate therapeutic effect. What we're talking about is just, having more of a comfort, when they're in bed and they get short of breath, and having a fan actually blowing in their
Why don't
face.
we, get some fans, have them here, yeah, the
Very small ones.
little
Yeah, the clip-on fans,
And then,
So-
at least keep them here, and if somebody needs one, we can run them out.
That's great.
Yeah.
Wonderful.
Yeah, because rather than ordering oxygen, you just give them a fan. A lot of times they feel better with that.
in my room right now. And the
So,
I'm for it.
all right, thank you.
If you guys want food, get it now, because we're gonna keep